Good evening, everybody. Welcome to tonight's webinar on providing improvement in carers, carers of our patients, and also our patients who are carers. This is going to be a really interesting topic, and we're looking forward to going through that. My name is Juliette. I'm one of the Program Support Officers at the PHN. I'm involved in intensive quality improvement projects, so if you put up your hand to do any of those sort of 6-month projects, you might get to talk to me a little bit more, but it's not about me today. Thank you so much for joining us. Before we get started, we'll just go through now. Why aren't my controls working? There we go. We'll go through some housekeeping in just a moment. But to begin with, we'd like to acknowledge the traditional owners of the land on which we're meeting today. We recognise their continuing connection to the land, waters and culture, and we'd like to pay our respects to their elders past, present and emerging. Okay, so each time I click, I don't get the response I want. There we go. All right, so just for some housekeeping, you're starting off today with all of your microphones on mute. We'd appreciate it if you could keep those microphones on mute. Now, are you able to hear me at the moment? I'm just looking at one spot and it's saying I'm on mute, but I don't think I am. Chris or Mads, can you tell me?
We can hear you.
Yeah, God. I can see 2 different icons and one's saying it is muted and one's saying it's not. So that was confusing. All right, anyway. So you'll all be on mute, and we'd appreciate it if you could stay on mute until you actually are asked to maybe elaborate on a question that you've put in or whatever. We do want to have some interaction in this webinar today. That would be wonderful, but we will just ask you to stay on mute for the time being until the questions are invited later. By the way, this webinar is being recorded. Just the content part is being recorded. The questions won't be recorded, just to protect your privacy. So you can feel free to ask whatever you like. When you do have a question, please put it in the questions box, which you'll see on the control panel almost all the way down to the bottom. You'll see questions. You can just type in there whatever you like, and thank you. Actually, I see that somebody did say I can hear you loud and clear, so there you go. So that's perfect. So if you put in your question just as soon as it comes up so that you don't lose it, we will save questions until various points in the webinar, but if you put it in there at the time that you think of it, that will really help, because we'll come back to that. And I do think we've covered all those aspects there. Just quickly, just wanted to mention some upcoming webinars that we've got going on. We've got one about blood cancer, abnormal white blood cell count, managing clots and anticoagulation. That's happening in another week's time. And then we've got a bunch of post, or what we're calling long COVID webinars. So they're dealing with the long-term lasting effects of COVID, if you like. The first one is happening on the 19th of November, and it's talking about chronic fatigue, which we know has been a really big issue for a lot of people who've had COVID. Then the second one, or we've already had the first one, to be honest, so that's the second one. The third one is about mental health, and it's dealing with post-traumatic stress after admission for COVID. And also what people have gone through when they've been diagnosed with COVID through work, and also the impact of isolation. And then finally, we're also going to be talking about the natural history of long COVID, so what we've learnt to date. So they're all going to be very interesting. You can jump onto our website to the events page to sign up for any of these opportunities. Also, if you don't already use Health Pathways, this is an amazing, oh, I don't know what happened there, just jump back. This is a really great tool that is available free of charge for all of the general practices in our area. It's really valuable, particularly for GPs who are really time poor and having to make clinical decisions using best practice recommendations, and it's just a lot to keep in your head. Well, Health Pathways actually has it all there for you. So you can look up, for example, if you're dealing with a particular type of cancer, for example, you can look up the best practice guidelines and who to refer and what the referral criteria are, and just everything that you need to know about that particular issue. And Health Pathways covers a lot of different clinical issues. So if you don't know about that already, and if you would like to know more, the website link is there, but you can also just ask your PHN relationship manager and they can help get you sorted out with that. Okay, we have opportunities for what we call our think tank, which is basically we want to hear from practice managers, practice nurses, GPs, allied health, everything in between. If you have a particular area of interest and would like to collaborate with the PHN on any of our projects that are relevant to your area, we would really love to hear from you, and you can put your hand up to be involved in our think tank. And in that, you would just be emailed or contacted to say, oh, hey, you mentioned that you've got an interest in mental health, for example. We have this opportunity coming up. Would you like to be a part of it? So projects and collaborations and things like that. So reach out to us if you do want to be a part of that. We're really keen to hear from any of you. I also wanted to just quickly highlight this family violence quality improvement project that we have going on at the moment. Now it's a rolling project. It's and what that means is it goes for 5 months, but we're actually recruiting practices all through next year, and I think partially into the year after that. 30 practices in total. So what that means is actually benefits for your practice. Obviously, you're going to get CPD points. You're going to get a whole lot of education and training and support in being able to recognise family violence and support people who are going through it and respond appropriately. There's also an incentive payment of $3,000 as well to the practice, so that can be really helpful as well. But what we're recommending is if you're interested, even if it's not the right time now, you could reach out to us and we can have it on our radar to get back in contact with you, you know, in the following year or whatever. So if that's of interest to you, please do let us know. Sorry, I didn't click through all the way there. But my clicker is not working again. Amazing. There we go. All right. You can just go onto our website to the expressions of interest or the current tenders and EOIs page, and you'll be able to fill out a form to say, yes, we're interested in knowing more. And there's the details for Irina, who is the project lead on that project. Also, I should mention that after the session, the slides will be available to you, and some other resources will all be sent to you as well. So you don't have to scroll madly down. You'll be able to receive these within a couple of days. Okay, one really important thing about today's session is it's talking about carers and quality improvement in relation to how we look after our carers. And we do have a workbook that is on its way. We're hoping within the next month, but Chris, our presenter, said to me before the session that everything is COVID willing at the moment. So do keep your eyes out. Of course, it will go out in our communications, our newsletters, etc., to you to say this is available. But keep your eyes peeled because we will have a carers quality improvement workbook available very soon. And for those of you who are looking at things like how do we record carers in our software, and how do we pull lists of those, that workbook has all that covered. So it's going to be a really valuable resource for you. All right, now I think that is enough yabbering from me. I'm going to introduce Chris and then we'll hand it over to him. So Associate Professor Chris Hogan is with us tonight. He has 40 years experience as a GP in Sunbury, and he believes in the general part of general practice. So Chris, you'll have to tell us more about what you mean there. Dr. Hogan is a GP representative on many state and federal medical committees and is an honorary clinical associate professor at the Department of General Practice at Melbourne University. Chris has held multiple roles at the RACGP, both in Victoria and nationally, including chairman of the Victorian faculty and director of the Victorian Research and Health Promotion Unit. He's currently a member of the RACGP Victoria Faculty Board and historian for RACGP Victoria. Associate Professor Hogan is heavily involved in aged care and has been on medical advisory groups for organisations including the National Asthma Council, Lung Foundation Australia and Celiac Australia. Lastly, Chris was the GP representative on the Victorian Tasman PHN Alliance and Carers Victoria project steering committee that has developed this education. Thank you very much, Chris, and take it away.
Thank you. Okay. Well, tonight we're going to just basically skip through most of these slides. I'm just going to try and highlight the main things, mainly because I can read a slide as well as you can, or vice versa. And the other thing being is that you already have the slides and notes. But, the recognition of the carer's role. Basically, carers can be people who provide care for a person who has a disability, a mental illness, ongoing medical condition, or as an older person with care needs. Now, the carers do not need to live with the person they care for, need to be the main source of care and support. They don't need to have to provide care every day or over many years. And they do not have to receive the carer payment or allowance. Carers are not always younger or healthier than the patient. They may have significant health issues themselves, and they may have a doctor other than you looking after their health needs, just to make life interesting. There's the continuous and intermittent type of carer. About 1 person in 8 in Australia has a role of a carer. Now, this is extremely important in COVID times because that means that these carers are actually at high risk of catching COVID, because if they catch it, their impaired person they care for can get that as well. And that's been making life very interesting. People become carers in different ways. It can happen gradually as a person's health and independence gets worse over time, or it can happen suddenly after a health crisis or accident. As my teachers used to say, all of us are one fall away from dependency. It is important not to confuse carers with paid care workers, such as community or aged care workers. This is an informal sort of attitude. It's useful to identify them in your practice if you can. Now, your workbook's going to go through how you can do that, but basically it's just a matter of asking questions. But for the other thing that's important is the carer can be your best friend or your worst enemy. And I've actually seen people die because their carer was not involved in treatment and didn't believe the doctor. So that's nasty things can happen. So the important thing is to look for people who you would think would benefit from carer's role, and then take it from there. One of the things to do that is the first appointment for a patient that you've met who's got long-term illnesses. And as you said, you can use practice management software and other information software as well. And it's also worthwhile recording that information, not only in the carer's file, but the patient's file as well. And it's the old story. Basically, to get a question answered in general practice, you ask open-ended questions about the support people need, the support that the carer gets. The carer can change over a patient's lifetime. I mean, in the town that I grew up in, when the carer was mum, when the people in the younger area, when they were children, and then it was the girlfriend, and then it was mum or the missus as they got older. Of course, every culture has different carers. Males can be carers, of course, and that's the way it goes. And it's, as I said, it's wise not to make assumptions, but to look. The carers themselves face physical and mental health and wellbeing challenges. They face social impacts because of the time that they spend looking after a carer. Oh, I can't go away. Joni will need me. financial hardship, because often they will either lose the ability to earn income, or they will actually expend money themselves. Now, there are tips for supporting carers in your practice, the checklists, the MBS items, making sure that they have the influenza vaccination, and next year, God willing, the COVID vaccination. Make sure that they're involved in the safety net. Safety net them so that there's someone, they know what to do if anything happens. They know what to do if there's a difficulty. And please be aware of the psychological distress that these people experience. It's worthwhile looking at the financial impact of services to see whether this is an issue. One of the things that one of my patients taught me when I was a brash young doctor was that it's not my decision as to what the patient spends money on. You actually need to ask them flat out, can you afford this or not? Just don't hold anything back because you don't think that they can do it. You must always, the patient is in control. The patient must have the information. And of course, there's the issue for potential abuse, financial, physical, sexual, that can occur when the carer gets under excessive stress or a nasty pasty to start off with. Now, any questions?
We haven't yet had any questions come through in the questions panel, but does anyone have any questions before we continue? I'll take that as a no and continue on.
Yes, as the Romans said, silence is consent. Identifying and supporting carer needs. Now, it's important to work with the carers to support their needs, the needs of the patient. There is the Carers Recognition Act 2012 that says that the carer should be respected and acknowledged, to be supported, to have their views and their cultural identity taken into account. Everybody's different. Have their social well-being and health taken into account, and consider the effect of being a carer on their participation in employment and education, especially if they're a student at school or university, TAFE, any ongoing education. Often you can act as an intermediary to assist these people if they get into trouble with their studies because of the time they spend being a carer. Yes, as I said, the opportunities to identify and support carers will depend on whether or not they're also your patient. And it's wise to see that if you can have whole practice discussions. We used to have our practice discussions in the morning because we knew when we started, but we could never predict quite accurately when we finished. You need to create opportunities, often to see them independent of the patient themselves, if they're your patient, and offer flexibility as much as you can to fit in with their appointments. It's difficult, I know, but it's just a matter of courtesy more than anything else. And the other thing too is to you can liaise with if the carer has identified the practice that they attend and is happy with you to talk with them, it's probably worthwhile liaising with the other practice as well. Now, in Aboriginal and Torres Strait Islander communities, the carers, it's more likely to be a carer, and that certainly is with my relatives who are of Indigenous origin. Now, carers from culturally and linguistically diverse communities may not understand the term carer. They may just see it as part of the job. But I'm the daughter-in-law. But I'm the oldest son. Or You know, I'm the only girl, or whatever. They just may see it as part of their role. That's in cultures where they have maintained their cultural identity. But there are barriers, not only because of preconceptions, which I've mentioned, but language and communication, lack of knowledge and understanding of the mainstream health system. And I think that applies to everybody. So I certainly find it confusing. I know my patients do too. And the other thing is inadequate access to culturally safe services. You actually have to have a dialogue with people as to what they consider culturally safe. And once again, assumptions are dangerous. It's always easier to ask. Now, in the LGBTIQ communities, carers can be isolated from others in their communities by social isolation, distance, financial disadvantage, stigma or fear or discrimination, and often the fear is more apparent than the actuality. Demands related to their role, and once again, access to affordable and includable services. But once again, it's not your choice as to whether they're affordable or inclusive. It's the patient's choice. It's the carer's choice. As you're aware, there's the usual challenges because of discrimination, fear of exposure or judgment. Not so common these days, still happens. Loss of contact with the family or culture, yeah, still happens. Lack of social and legal recognition of relationships, which can be really challenging. But the community support workers can have access to a whole range of advice and legislation that has made this a lot easier, especially when it comes to making wills, powers of attorney, and also dealing with superannuation and who gets the superannuation benefits. Lots of progress from when I started. These caring situations can be invisible. Not as much as they used to be, still happens. And but what happens is that often under the stress of the caring relationship, they find it hard to be themselves in their care situation. Now, for a carer-friendly practice, basically it's just courtesy and communication. Physical accessibility, no barriers, no physical barriers to access, not like the old-fashioned dentists who used to have their practices on the first floor of a building, which was only accessible by stairs. It's knowing when the consultation times are available. I need to know about the access to medical support, feedback on systems and processes, and safety netting and follow-up arrangements. Pretty straightforward, really. Now, there should be always take-home notes, not only for the patient, but also for the carer. It's one way of maintaining communication between carer and patient as to what's going on. And notes are always also useful for the patients. My wife was a pharmacist who used to work next to me in her pharmacy next to me. And one day I spent 40 minutes with the patient explaining the ins and outs of asthma management. And the patient went next door and my wife asked them, and what did the doctor say? And they got the response. But she said, did the doctor give you anything? Oh, yes. And pulled out my notes on an asthma management and was then able to follow it through. So basically it's medicine's like the law. If it's not written down, it didn't happen a lot of times. So notes, information, or access to websites or anything is important. The other thing that you need is access for interpreters in a COVID-safe manner. And once again, information packs and websites for carers and family members, not only on caring, but also on the conditions being treated, as I've already explained. Referral pathways are available for the carers, the health pathways, career counselling service, etc., etc. They are all in your notes, and they're fairly too extensive to go through at the moment, as is the mention of respite services and peer support. Now, what happens when the caring role finishes? Now, this can happen under a variety of conditions. One of the things that happens is that the person who's been cared for leaves home. And it's sort of a variation on the empty nest syndrome. But every caring experience is difficult and as different in how an individual cope after caring duties have finished. You get the feeling of emptiness, loneliness, low self-esteem, depression, anxiety, and guilt. So, you know, it's sort of an exaggerated empty nest syndrome. Now, people don't only leave home as an improvement in their life, it's also as a deterioration. Admission into residential care can also result in a sense of bereavement, although the caring role may continue in some form. You know, I was fortunate in my area in that we had aged care facilities in the town, which made life a lot more interesting. So that we didn't get divorced by illness, for instance, or anything along those lines. The carer often experiences feeling guilt and anxiety, although the move, even though it's inevitable and logical, but convincing the head is easy, convincing the heart, not so much. And as I said, the carer continues to visit the patient in the aged care facility, but there's often a sense of failure that they couldn't keep them at home. And this can impact on their interaction with the care facility and can make life very difficult for the caring staff. But as long as the staff are aware of this and take time to explain, so much the better. Now, the other thing that happens is if the care recipient dies. Now, it doesn't matter how sick the person is, and often the longer that they've been sick, the more challenging it is, because it's our natural tendency to think that things will continue. I understand from personal experience, my father had unfortunately severe dementia before he died. And when he died, I considered it a blessing, but it was still a shock and still took away. And, you know, I've been dealing with this for other people for a long time, and I still felt the same. Well, we're human. Now, the other is the practical aspects of that. If the care recipient dies, the carer payments, if they're receiving them, often come to an end within a few weeks of death. And this may result in housing issues if the person who has died was a leaseholder for a joint home or owned the property. And this is where establishing a decent will and managing the affairs on admission to the care facility is extremely important. Any questions?
Yes, Chris, you mentioned earlier about people from culturally and linguistically diverse backgrounds may not understand the term carer. How would you, you know, in the absence of an interpreter, what would you usually go about to say, are you a carer, without using that terminology? How would you put it?
Well, well, the answer to any question in medicine is it depends. I think the question is basically to keep your mouth shut and your ears open. It's a matter of asking them, not so much are they a carer, is but who do you look after? Is there anyone else in your family? Your mother, grandmother, grandparent, all that sort of stuff. We used to use the carer in old age as the person being cared for in old age as female, because when I was a fledgling, men didn't live to old age, but they do now, which is rather comforting for somebody in my years.
Good stuff. Has anyone got anything else that I'm just going to check again because it looks like something's popped up, but it's really tiny. So let me just bear with me for a second. Okay, this is a comment more than a question. Carers don't often label themselves as a carer. That's correct. Yeah, so it's a bit of an art form then, isn't it, to try and sort of delve in with your questioning to get to the bottom of whether they are actually providing care to somebody who is needing that support, not as a minor, but as, having a disability or an illness or something like that. Correct?
Correct. Yes, it's often, often people think that when GPs sit down with their patients and they just have a chat. What they don't understand is that most GPs are trained as expert interrogators. And what we're trying to do is to get an idea of the person in their context, who they are, what they do, how they cope when they're sick, how they cope when they're well, what behaviours they have, this, that, and the other. And it's the mark of an expert that they make the job look easy. Well, it isn't anything but easy. And one of the things that always amuses me is that when people try to duplicate our role and don't have the same success, but then keep at it because it has to be easy because it looks easy. Very amusing.
It's a challenge, that's for sure.
Oh, yeah. But it's fun. Okay. You never know what's going to walk through that door. Or if they'll walk out. All right, we'll move on.
Yeah, now I'm just looking again. I think that's it. My questions pane is a teeny tiny, so it takes a bit of time, but thanks for your patience.
Not a problem. Involving the carer in patient care. Once again, it's an art form. Involving carers and listening to their concerns when devising a care plan is likely to result in better cooperation and effective implementation. Now, most people are logical. You wouldn't believe it, but most people are logical. But the reason their logic diverges is because the beliefs on which their assumptions are based. And one of the important things that I found, my children are the fourth generation of teachers in our family, and they always said that if you want to know a question, if you want to know whether a person has understood what you've said, ask them. So what do you think asthma means to you? How do you think asthma affects you? Or something similar to that. So rather than talk, it's a matter of listening. The Chinese say before you pour the tea, you must first empty the cup. And there's a long story behind that. But basically what happens is that very few people are ignorant about everything. They know a lot, or they think they know a lot. So the important thing is before you start telling, you should start asking. Or as Dad used to say, we've got one mouth and two ears. We should use them in that ratio. Now, privacy and confidentiality. What to do when your patient is reluctant for the information to be shared, and what to do when the patient lacks the mental capacity to make a decision about sharing of information. Oh, something nice and easy. First thing, talk to the carers and other family members together. If the patient's in the room with the carer, you are totally entitled to speak about it. Adopt a problem-based approach with carers. Ask them, really, communicate. Use medical records, medical websites, handouts, and information tools. Use the carer in multidisciplinary conferences. Explain what you're doing. Give their handouts. Ask. It's not rocket science. Actively involve the carers in the planning and information of long-term management plans. One of the reasons the carers may resist you is they do not adequately understand what you're doing. Actually, it's the main reason. And develop holistic and shared decision-making approaches to treatment. Well, see, the main thing about medicine these days is that we found we have a whole range of treatments. They only work if the patient actually takes them. And it's important to encourage the patients to take the medication. If you don't take it, it doesn't work. Coordinate and integrate the agendas of carers and other family members with that of the patient and your own agenda. Discuss, negotiate, that's what that means. When can we do it? Oh well. Enable sharing of decision making and agree on management plans. This is basically a tradition that I see among my Aboriginal relatives. They'll sit down, they'll talk and talk and talk. Bit of humour, more talking. But the thing is, it's basically conversation. What do you want? What can I offer? How can we help ourselves? What do you think's going on? It's discussion. Common sense, it's courtesy. Yes, and as I said, carers may have different information. Oh boy. Working with carers of people with a mental illness is a real challenge. Families and carers should be recognised, respected, supported because they have troubles themselves, a whole range of troubles. It's not only because mental illnesses can be inherited or passed in families, which is, familial or congenital. It's because the disruption caused by severe mental illness can affect everybody in the family partner and partnership. And what they used to say is the person who presents with distress in situations like this is not the person with the biggest problem, it's the person who can cope the least. So you're actually extending your care not just to the carer, but to their family as well, which if you've got a community where those people are in close proximity, not too complicated. It's one of the reasons I like working in rural areas. But these problems need to be identified and the people need to be engaged as soon as possible in the assessment, treatment, care and recovery when it's possible. There are emergencies in mental health and they're happening now. We've only just found out from the health department how severe the impact of COVID has been on the increase in mental illness. And, organisational practice governance is just common sense. Do what you can for whom you can. Talk. Services must have clear processes in practice. In other words, be consistent. Be fair. Privacy and confidentiality is important, but realise and always realise that there are limits to medical confidentiality. We must break confidentiality if someone's life is at risk, if a crime is about to be committed, a serious crime is about to be committed, which is, if you ever read the inquest into the Queen Street massacre, you'll understand that information wasn't always followed. And when ordered to do so by a court or under legislation, such as reporting an impaired driver, which can be from mental illness, unfortunately. Services must, as I said, you've got to have regard for the impact of mental illnesses on family members and assist them as much as you can. It's a real dog's breakfast in it, and often it's the quiet kids who are forgotten, but they're often the ones who suffer the most. So sometimes, well, I mean, for me, it was a bit easier. I was able to do home visits. That's not quite so practical these days. The Privacy Act, the Mental Health Act informs us, and the Act is actually readily available as well, that carers need information to assist them in that caring role, and it authorises clinicians to provide this information in specific circumstances. It's worth looking it up and dragging it through. That'll be provided for you, I expect, in the handout, because I certainly got it as part of the handout. Open communication with patients, families and carers about privacy. What's private, what isn't. Confidentiality, what's confidential, what isn't. And information sharing is fundamental. Start with the ground rules, and then you can all work together safely. As I said, within limitations, the consumers have a right to privacy and should have the opportunity to decide what information to be shared with their carers and families within limits. They have to be actually competent to be able to share that information, and the Mental Health Act covers through that. You know, as is said quite readily here, providing general information and hearing from a carer or family member does not breach privacy or confidentiality. People can tell you anything. You can't tell them everything. That's the important part. Medical decision making when a patient cannot provide consent is a big one. And the Act allows people to complete an advance care directive, appoint a medical treatment decision maker, and appoint a support person, which is very important. Advanced care planning is possible only if they have decision-making capacity at the time. There are two forms of statement a patient may include in their advanced care directive: an instructional directive and a values directive. If medical treatment is clinically indicated and the person does not have decision-making capacity, a health practitioner must obtain consent through an instructional directive, or if there is none, obtain consent from a medical treatment decision maker. What's that? And here it is. But first of all, they have to be willing to be involved. It can be the person appointed by the decision-making person, a guardian appointed by VCAT, the spouse or domestic partner, the primary carer of the person, the adult child, parent of the person, or an adult sibling. Questions, please. Any questions?
I think we don't have any new questions at the moment. Does anyone have anything they want to jump in and ask at the moment?
Because these are the hardest questions.
Yeah, you can unmute yourself if you want to jump in and ask something. I think all quiet on the Western Front.
No answer is the stern reply. All right, health referral pathways and resources. This is just basically the health pathways, the mental health services for carers. Actually, this has just been amended just recently with the development of the HOPE project for hospital outreach services, which are being started up in several areas. The respite services, My Aged Care, NDIS, resources for general practice and support codes. You'll be issued those handouts as much as we can, with the rest of your resources tonight. Carer awareness, case studies. Well, I'm sure you could all think of one or more that you could come through. In fact, I'd be delighted if someone would be able to volunteer one, such as you can see Amanda, 36, dad's got cancer, she's a single parent, and there's no one else. Only trouble is he's 100 kilometres away. Omar's 62, he's got rheumatoid arthritis, and his wife's been discharged home from us with a stroke. Amy's 14, multiple sclerosis it affects her mother. Her father's given up work to rely on her, but relies on Amy to give him a break and help out. So I think we can just, is there anyone who's got a case of a carer that leaps to mind they can tell us about? Okay. Okay, we've got Aisha, 20 years old. Last seen 4 years ago, and even though she started with our practice 10 years ago, she comes in extremely upset. She's struggling to cope with uni, looking after her mother is disabled after a head injury. How can we provide help? Well, we could record that Aisha's, or Aisha, I can never tell the difference, is a carer on her file, record that on her mother's file, and find out exactly what it is that she does for her mother and when she does it. And provide her with information and resources that you've got. And the other thing too is that they may or may not need to be culturally appropriate. Ask whether they need to be culturally appropriate. And of course, look after Aisha's health herself, her physical and mental health. And once again, you can act as an intermediary about the problems she's having with her university studies and see what you can mutually do for that. There's a lot more flexibility, especially at the moment when nothing's on site. Linda, 64, terminal breast cancer, well, stage 4, advanced breast cancer, and becoming more reliant on her partner, Julia. They've been together for 6 years and she's in a caring relationship. Once again, there's an issue. Julie refuses to share information. Sorry? Yeah, Linda refuses to share information with Julie. Well, what do you do here? What questions do we need to answer? Anyone?
I think you'd need to have a discussion with Linda and say, hey, can we get to the bottom of this? What are your concerns about sharing the information?
Yep. What else?
Maybe is there any sort of information that she wouldn't object to sharing as opposed to some that she does object to sharing?
Okay.
Sort of weed out what's what.
Okay. The other thing to do is what happens because she's got metastatic cancer. How does that affect her decision making?
Yeah, that's a good point. So she's potentially not all that disposed to making stable decisions. We'd need to explore that. It's not to say that she's not able to make them, but we'd need to make sure that she is.
Yes, if she's got a disintegrate met in her frontal lobe, that's going to interfere with her capacity. So you actually have to. The first thing, the reason this came up is because you need to make sure of her physical capability of making a decision, and doing a mental state and a psychiatric history is also important. Now, you don't need to be blunt about how you do that. You can be quite subtle, but if you wish. But you always need to keep in mind that her condition isn't affecting her capacity. And now, if that's the case, what do you do then? If it is affecting her capacity, what do you do then?
Gosh, that's a tough one. Where are the GPs?
Come on, guys.
Yeah, we need some help here. Any people got any inputs that they'd like to add? What would they do in that situation? Would we be getting the advanced care directives books out to sort of see what guidance they have to offer?
Yeah, exactly. You not only need to do that, but you should also, I think it'd be wise to get a guardian appointed. And that would mean a trip to, you'd first of all need confirmation that she is incapable of providing that sort of stuff, providing consent, and you would have that once you've got hard evidence that that's the case, you can then make an application, or Julie can make an application to become a carer.
Well, you said before it's not easy, and there's a good example, because that's really tough stuff that you have to wade through there.
Oh yeah, and I mean it's not that it, and it's actually this person's real, but and the Mets were real too, unfortunately, and she hemorrhaged into the Mets, and that was it.
Oh gosh.
But there we go. As we've said, it's important to establish the reason why Linda does not want to share. And if it's, I mean, this goes through the other things, but what had happened was embarrassment. There was in this particular case, rather than the real one, there was a string of overdoses that she took after an abusive relationship in her 20s, and she felt embarrassed about, didn't want her to know. Of course, her partner couldn't care less, but.
I have just seen a comment that came through, and apologies, I didn't see this earlier. It's along the same lines as what we were just discussing, but he said, I would think we need to encourage or explore options to appoint an advanced care directive. So that's exactly what you were talking about.
Yes, yes. Yeah.
Good stuff.
Yeah, this is where I asked any questions. Oh well.
Bit of a quiet one today. We'll open forum if anyone's got anything further they want to add at this point. Please jump in, open your mics and say whatever you want to and shock us. Go for it.
Hey, I'm a parent of 4 and a grandparent of 3, and it takes a lot to shock me.
It's been a very good discussion. I did see somewhere in the slides at some point you'd mentioned consider whole of practice opportunities to identify carer needs. When you wrote that, what sort of things were you having in mind, like whole of practice? What could other members of the team that aren't the GPs, you know, the nurses obviously, but what about receptionists? What sort of things were you thinking of when you wrote that whole of practice?
Oh, it's pretty straightforward, is that when you're dealing with whole of practice, the important thing is to ask everybody who's involved, because it's always important to ask other people involved as to what suggestions that they have had. And you know, I used to be involved. We were talking about you know, the general part of general practice, and that is that it's always important to ask the rest of your practice as to what's going, because I know that some of my nurses, in fact, had done a lot of psychiatric training and had those resources. Another had been an administrator for Centrelink. Others had. You don't know what resources people have in a group until you actually ask them. And the other thing too is they also have their lived experience, and often they will have been in situations of caring themselves. And the fact that they want to work in a general practice means you do that. So basically, the other thing too is that when I was doing practice management training, they said if you want to know how a job's done, ask the person who's doing it. Brilliantly, not very complex suggestion. And what happens is you ask the receptionist, how do you identify a carer? Oh, well, I know most of them, and I can tell you that because I see that when their kids went right with school with me and all that sort of stuff. This is what's happening, and so you can actually. Oh, the other one said, oh, they always miss appointments on a Thursday. And I thought, okay. I said, do you know why? Oh, because they've got to look after such and such. And sometimes, she gets a dose. She gets agitated on this because the Thursday, her partner goes out to collect for stuff like that. So it's all sorts of incidental things like that. I mean, we had our nurses used to do the aged care assessments and the Indigenous aged care assessments, which always amused me because the people are being tested were younger than I was, but that's not the story. And the whole of practice can actually provide skills that aren't obvious because of their role, is what that means. And they can also look at ways that you can adjust IT systems, all of that sort of business. That's what basically we're talking about.
Yeah, good stuff. All right. We had another comment here that said, just going back up to the top. In regards to referrals, it is important to refer carers to the carers gateway for services such as respite, etc. Carers Victoria can also provide some supports and education to assist carers manage issues relating to their own and the person they are caring for care needs.
Yep, perfectly reasonable. As I said, that actually will be on the handouts.
Yeah,
it's
very good. Definitely good resource there. Okay, well, I think that is it. May I remind everybody that there's another comment here. I'll just read that in a moment. I'll just finish my sentence. There will be an evaluation for this session in your inbox once this session is finished. We would really appreciate it if you could fill that out quite quickly while the material is still fresh in your mind. That would be really wonderful. It's very important to us to be able to evaluate how these have gone and really be able to tailor to your needs and requirements. So that would be great if you could fill that out. Okay, now this last comment here says, in practice, it's very difficult to get paperwork and linking patients or carers info into NDIS or NDIA. It's not like My Aged Care Online. Is there any MBS item numbers available for carers? A bit of a double whammy question, that one.
The first one, good luck. I know I share your pain. What we used to do was we would delegate tasks like that in our practice to either an administrative assistant or one of the nurses, and sometimes even the pharmacist would fill that role in. But so we get some help if you're getting burdened by paperwork. It's sharing it out among other people who are available in your practices is quite useful. And the second question?
Are there any MBS item numbers available for carers?
Not specifically at the moment. I know there's been a lot of pressure for that to occur, but I'm not aware of it being fruitful as yet. But the last time I asked was in January, so can't be sure there. But of course, once again, we mentioned it in the handout. The thing that I always felt was incredibly useful with carers was was a care plan, and using that was quite useful.
Yeah, for sure. It's a really good tool. Okay, well,
Oh, the other thing,
Yep.
you asked a question before, and that is, what do I mean by the general part of general practice? And what I mean by that, what I mean by the general part of general practice is that general practice provides with an incredible range of opportunities. As a GP, I've been involved in obstetrics, anaesthetics, minor surgery, road trauma, disaster management, research, a whole range of other things. In my lifetime, general practice hasn't been a limitation; it's been an opportunity, and you know, it's gone from the theoretical, from the cutting edge practical to the hard edged theoretical, and it's been fun. That's what I mean by the general part of general practice.
It's definitely very diverse, that's for sure.
Oh yeah.
Yeah.
I think I remember the last time I was bored. It was December 1970.
Oh, fun. Okay, well, I think that's the end of the session today. We've gone a bit early, so that means everybody gets dinner a little bit earlier, maybe.
Oh, what a good idea.
Yeah,
Okay, thank you very much. Goodbye, everybody.
Thanks so much, everybody. Please remember to do that evaluation as well. And thank you, Chris Hogan, for your time. Really appreciate your insights today. Thanks so much. Bye-bye, everybody.